Welcome to this Physician Renewal Week session, which is entitled Increasing Professional Satisfaction by Enhancing Patient Outcomes Through Proton Therapy with Maryland Proton, a corporate sponsor of the Montgomery County Medical Society. I am Marissa Valeri. I'm the Physician Outreach Specialist with MCMS. I appreciate you joining us today for this valuable educational program. I encourage you to review all the other sessions prior to our evening program. All the sessions of Physician Renewal Week were designed with your well-being and that of your practice in mind. Registration for all the sessions remains open, so it's not too late to sign up. It is my pleasure to introduce our topic and speaker for our program. Dr. Daniel Kunaprayoon is Assistant Professor at the University of Maryland School of Medicine's Department of Radiation Oncology. He will be discussing how proton therapy differs from standard radiation therapy, new therapies available in cancer treatment, and the resources and processes available to ease patient access and ensure communication of patients back to their primary oncologists and specialty physicians. Please join me in welcoming Dr. Kunaprayoon.
Thank you, Marissa, for that lovely introduction. And thank you, Medical Society, for allowing me to discuss proton therapy today with you all. I'm gonna share my screen now. Can you guys see that okay? Benefits of proton therapy?
Perfect.
Great. So that's me, and you can reach us anytime at that number. But slide here. So, our goal really is to be a center of excellence and value for the region, basically. And our mission is extended to the surrounding areas and partnering with everyone in the surrounding region. We're based up here in Baltimore, Maryland, but we serve patients from all kind of districts, and as far as Pennsylvania, Virginia, Delaware, and Eastern Shore, and Western Maryland. So that's really the goal of us. Go back here. Interesting thing about the way we have our services set up is that here we're really a cost. The way we partner with our insurance providers, we're a cost neutral center. So the cost of proton therapy that we have is the same as conventional radiation therapy. So and that's explicitly designed to become we're just interested in trying to get patients the best level of care that we can. You're going to see a lot of slides that look kind of like this, which show their CT imaging, and we call these kind of dose distributions, and you can see that they have they're almost like heat maps of where the radiation is deposited into the body. We call them color washes, but that's how you can think of it, is a map of the radiation on CT images. And there are going to be a lot of slides like this just showing the difference between protons and photon radiation. And here, for example, this is a classic example. This is something we call craniospinal irradiation. This is for a young pediatric patient, but you can see here the goal is to treat the spine with radiation. And you can see with protons, really just the spine is being targeted here, and that's all that's getting radiation here. Whereas with X-rays, you would have radiation kind of going not only to the spine but to other parts of the body. As you can see on the top left and bottom left, you can see kind of the anterior part of the body is getting radiation, and you can see that also in cross-sectional imaging on the right. This is just another example where kind of delineating in liters how much more healthy tissues irradiated with conventional radiation compared to protons. And on the left, you can see the conventional radiation with protons, on the right, proton therapy, and it's really up to 5 times a greater volume being radiated with something even conventional IMRT is delivering that. And you can kind of see in color, the areas that are getting additional radiation. Within the the high dose region where it's just the red here, can you guys see my mouse? That area is still getting the level of radiation we want, but all this stuff here, we would like not to have radiation where, that is being delivered with conventional radiation. The reason we can do it with protons is because it's a physical property of protons versus photons. So this is something called the Bragg peak. I wouldn't get too hung up with the vocabulary, but all it shows is that within tissue, protons are delivered at a certain depth, and then after that depth in tissue, they fall off and goes to 0 here. So we can control where the radiation ends up in the patient better than we can. Not better than we can, but the characteristics of it are such that there's a steep fall off at a certain point. Whereas with photons, you can see the characteristics are the radiation keeps going within the body. X-rays don't stop here, and you can see that on the diagram here. Protons stop, photons don't. So this is just a pie chart of the patients that we've treated at the Maryland Proton Treatment Center up and through, I think this is current as of March this year, and about 3,000 patients so far, pretty much from every disease site, including pediatric cases as well as re-irradiation cases where the patient has already gotten radiation, usually with conventional radiation, and those are very challenging cases that are from difficult to impossible to kind of retreat with regular radiation. And these run the gamut, though, from CNS tumors to genitourinary to lymphomas to head and neck to gastrointestinal, breast, thoracic. So really everything has a role. We don't have to spend too much time on these, but just to give you an idea, this is a tumor at the skull base, and you can see that with regular radiation on the right, that there is more of that low dose going to more of the normal tissue. And so proton therapy for brain cancers, we tend to use it a lot for many different tumor types, from craniopharyngiomas to meningiomas to pituitary tumors, a lot of things kind of at the midline or central structures that are hard to really get good access point to it. We've treated over 430 patients with brain tumors, and typically with brain tumors, the treatment course is over about 6 to 6.5 weeks. You're seeing a lot of this now also, as the field is shifting from whole brain radiation to kind of treating more focal disease, that a lot of the benefits of proton radiation apply to this population. This is a similar example, but the important note from this slide is we do have a phase 3 randomized trial for glioblastomas now. This is the same slide. So advance here. So this is a slide showing the differences kind of for prostate cancer, and prostate cancer, you're able to spare a lot of the kind of normal bladder and bowel, and also pelvic bone marrow. So proton therapy really has a role here from everyone from intermediate risk to even, I think we see a lot of the benefit in the high risk patients because that volume that we have to treat is a larger volume. But really with proton radiation, and I don't know if we have another slide coming up, but a lot of the benefit we've seen is actually in the rectal dosing. And this is a slide that kind of shows the mean reduction in dose going to the rectum and you can see the IMRT is kind of up top here, and for proton on the bottom here, and they're just lower volumes of rectum that are being radiated with protons, and that's important because that accounts for a lot of the toxicities we see with radiation for prostate cancer, for example. For breast cancer, We've had a lot of studies over the years showing that increased risk of coronary disease and coronary events with increased risk, with increased radiation to the heart. So really, we really try to minimize the amount of heart that is radiated when we treat breast cancer. And there are a lot of techniques to do this, even with conventional radiation, but we're finding that, you know, we are able to do this at an exceptional level with protons. Here you can see the kind of outline here, the RCA and the LAD arteries, and you can kind of see where they are on this CT scan here. But with protons, you're really avoiding them, you know, oftentimes completely. Whereas even with the best kind of conventional radiation techniques, there's still at least a low dose going to the, at least a low dose, and sometimes even often a higher dose going to the LAD. We also have phase 3 trials for this ongoing right now. So these are the reasons we think about it. We do think that the patients who benefit the most are patients with left-sided breast cancer, as the heart kind of sits right underneath. Younger patients, patients who've already had radiation, either for, you know, sometimes for a lymphoma or for a prior cancer, triple negative disease, inflammatory breast cancer, patients with genetic syndromes who may be predisposed. And we've treated a fair number of patients with breast cancer at the center. This, I think we've seen a lot with the ongoing trial also. This is a slide kind of depicting the dose distribution of protons versus IMRT for head and neck cancer. And you know, I think depending who you talk to here, there are a lot of folks who really have had great outcomes with head and neck cancer with protons. And that's, you know, it depends on what site you're talking about within the head and neck region, but that's one that can often be associated, you know, even with protons, with toxicity going to the normal structures such as the salivary glands and the oral cavity and the lips. And a lot of times those, especially towards the end of treatment, get unbearable. And I think that protons really has an ability to spare a lot of these structures that, you know, we don't really want to treat, but they're in close proximity to the disease that we have to treat. So I think tonsil cancer, definitely the nasopharyngeal cancers, and you know, some of the nasal cavity and paranasal sinus for sure see a big benefit. And this just has to do, you know, the higher up you go, you see sparing of the optic structures as well, the optic chiasm and optic nerves. So we do a fair amount of head and neck cancer here. We've treated over 350 patients with head and neck tumors. This is an example of esophageal cancer, and you know, this is one that I personally like seeing esophageal cancers treated with protons a lot, because there is increasing evidence that's kind of sparing the heart and lung offers a big benefit, and especially when you have to treat kind of long strips of esophagus and the surrounding areas. The heart and lung is really what can limit the amount of radiation you can get in, and the toxicities we see are, you know, the esophagus is still going to get the high amount of radiation that it needs, but when you can spare the amount of normal heart and lung, really the lung, these are people who oftentimes have, you know, long cardiac and smoking histories anyway. So anything you can do to reduce that radiation to those areas, it goes a long way. Besides esophageal cancer, we've treated a fair number of rectal cancers and anal cancers, and also in particular rectal cancers that have already had radiation previously. So we treat a lot of pelvic cancers with re-irradiation, often a twice-a-day treatment, and these we've had a lot of patients do quite well with that as well. Proton therapy for lymphoma is also an important one. This is one of the ones you're seeing on the screen here is kind of a mediastinal lymphoma, and you can see, I think this kind of lower view, the sagittal view on the bottom here shows it really well, how you're really able just to target, again here you're sparing the heart, which is a big issue for similar reasons to, as we talked about with breast cancer and the esophageal cancer. That a lot of the, especially in Hodgkin's, for example, Hodgkin's lymphoma, when the patients already do very well, the goal is really to decrease toxicity, and protons is just a no-brainer way to kind of reduce that. So we treat Hodgkin's lymphoma, but also the non-Hodgkin's lymphomas as well, and I think this makes up, especially in our younger cohorts, this makes up a good portion of the lymphomas. We have several trials open right now, from just registries to randomized studies to from breast to lung to head and neck to prostate to GI and pancreas and liver cancers. We have done a very good job with accruing to trials on the NRG network. We were the #1 accruer for NRG trials in 2019 and #5 worldwide. And I think last year in 2020, I think we were also the #1 accruer. Barbara maybe can attest to that. And a lot of these are, in a lot of sites, tumor sites, we still don't have enough data on proton versus photon trials, and those we do try to utilize as much as we can. So there are a lot of benefits of proton therapy that have been reported. This is just a sampling of them, but you can see that outcomes range from increased overall survival to increased quality of life to decreased amount of use of something like a feeding tube to decreased hospitalization rates. So there are several metrics for the benefit of proton therapy depending on the disease site. And this is something we hope to see more and more benefit of. And it's reassuring to see these studies and these outcomes, because a lot of times the technology can move faster than the follow-up. So this is something that we like to see and affirms everything that we're doing. These are some of the populations that we think have some of the biggest benefits. And we've gone over a fair number of these already. So in breast, locally advanced cancers, especially when you have to treat the internal mammary nodes, which typically add more heart dose. Within the central nervous system, sparing the normal brain, and especially things at the skull base or things that require re-irradiation. Let's see, a lot of these we've talked about already. In the gynecologic cancers, when we have to treat sometimes the para-aortic areas, or which is just a extension of a longer and higher field, basically treating more areas, we feel that protons does an excellent job with that. Young patients, obviously, sparing as much normal tissue as we can, from our pediatric population to lymphomas. For thoracic cancers, this is similar idea to what we discussed for the esophageal, but especially with lung cancers, where a lot of their tumors they either have diseased lung or lung tumor. You really want to spare as much normal lung as possible, and this can be either in the upfront setting or post-pneumonectomy setting or post-lobectomy setting. So we find that there's a lot of benefit for protons in those patients as well. We have a very coordinated team here that works with a lot of different centers. We're certainly a tertiary referral center where we're working with the regional centers, as well as even our main downtown campus, as well as a lot of our satellite hospitals. So we, over the years, have gotten very good at working with our, all our oncology team, from surgical oncology to medical oncology to ancillary services, and we have dedicated support staff to make this as seamless as possible. We have on-site social worker, nutrition. We have, everything from soup to nuts, from parking to getting here to staying here to commuting here. We have all that set up. So that's one thing that I think has made things very easy for patients. Yeah, this slide goes into some of that as well. So we have our on-site concierge that helps with everything. So, our goal and our job really is to create, to give our patients the best kind of care, and that a lot of times the financial and the coordination part goes neglected, but that's something we work very hard at. We have other resources like Hope Lodge and Ronald McDonald House that for patients who live far away, to kind of help them at least, sometimes just Monday through Thursday or just during the week, they stay here. So just kind of some take-home points to take away, that radiation, radiation with conventional radiation is still going to be how the majority of radiation is delivered throughout the country. Most cities don't have proton centers. In this region, we're lucky. We're fortunate to have, a state-of-the-art variant center here. Protons really enable the treatment of complex tumors that have already been treated, tumors that would otherwise be hard to really treat adequately with conventional radiation. We have a number of trials that are open that help us continue to study and refine who benefits the most from this advanced technology. And we're partnering with all our regional providers to make this a resource that's available to even patients who don't live far away or don't have this directly accessible. And I think that is it. If anyone has any questions to talk about or go over.
Great, thank you so much. If people have questions, you can either put it into the chat box or you can unmute yourself now. And I'll give everybody a second.
Hi.
Yes, Dr. Pham.
Yes, hi. Thank you very much for this presentation. I'm actually a private practice otolaryngologist. I met Barbara a couple of times. Thank you for coming down. Yeah, I actually don't do a whole lot of head and neck anymore, but I really appreciate the information. I actually send stuff to Dr. Hatton. So thank you for your support. So I'm sure that appropriately so it was referred from down here up to Dr. Hatton, and then he'll refer appropriately. But it's really I really like that beginning slide as far as photons versus protons. I think we all sort of need that.
Yeah.
Yeah.
No, and I work with Dr. Hatton a lot. We've had a couple of cases over the years, and he's an excellent surgeon, and we've a lot of times we work very closely with our ENT colleagues here to get people in either for definitive radiation or post-op radiation or chemo radiation. I mean, all of us have to work, and we have a fair number of head and neck trials up here as well. So that's great to hear.
That was great. Yeah, it was really good. Sort of like, because I didn't know about all the other locations as far as sites that also was treated. That was excellent. Thank you.
Great.
Thank you so much. Any other questions or comments? Okay, having heard none, I'd like to thank our speaker and all of you for participating today. We welcome your feedback and we look forward to seeing you again soon.
Thank you.